welcome this afternoon. Thank you for registering for this symposium. We're very pleased to have the panelists that already have been introduced, but also the following: Mike Sack and Bruce Korff. And Mike Sack, as many of you know, is a professor in the Division of Infectious Diseases, founder of the UAB's 1917 clinic, director of the NIH-funded Center for AIDS Research, and among other things, Jim Straley Chair in the AIDS Research, as well as the Associate Dean for Global Health. And I think actually Dr. Tita is going to take over that position fairly soon after the announcement of Dr. Sack retiring. However, in his current role and also among many accomplishments, Dr. Sack is also the PI of the CIFAR Network of Integrated Clinical Systems, also known as CINIX, which is a clinical cohort across several centers for AIDS research in the United States. And he'll be providing information with regards to that cohort today. Dr. Bruce Korff is the Wayne and Sarah Cruz Finley Chair in Medical Genetics, Chief Genomics Officer for UAB Medicine, co-director of the UAB Hudson Alpha Center for Genomic Medicine, and Associate Director for Rare Diseases at the UCAL Personalized Medicine Institute. He's a medical geneticist, pediatrician, and child neurologist by training, and he will be speaking to us today in his role as the UAB PI for the All of Us study. So with that introduction, or brief introduction on our side, we actually would like to foremost, welcome our panelists, but also everyone else on this this afternoon attending. Thank you. And we would like to start by a brief introduction from each panelist with regards to the cohort that they're presenting today. And again, just for context, so people know, what we're talking about and how this may have impacted your operations with regards to COVID. But this particular introduction really more kind of like a, distant view of, what the specifics are of your cohort. And I'd like to start with Dr. Tita. So can you tell us a little bit about your study?
Yes, certainly. Thank you, and welcome everyone. So I'm going to talk about the CHAP trial. CHAP is a US multi-center randomized trial to evaluate whether antihypertensive therapy given to pregnant women with mild chronic hypertension, that is systolic blood pressure less than 160 and diastolic blood pressure less than 110, whether that is beneficial and safe during pregnancy. The primary outcome for CHAP is a composite of fetal or neonatal death, preeclampsia with what we call with severe features, so really serious preeclampsia, placenta abruption, which is a separation of the placenta and can be catastrophic for the infant or the fetus, as well as for the mother, or preterm birth prior to 35 weeks. So a composite of these outcomes. The safety outcome is poor fetal growth, which has been associated with antihypertensive therapy in pregnancy, and by itself can lead to fetal death or long-term cardiometabolic or neurodevelopmental problems. The trial is funded by NHLBI with a data center here at the School of Public Health with statistics, Jeff Sikowski and Gary Cotter, and the Clinical Coordinating Center here at OBGYN and the Center for Women's Reproductive Health. We've had about over 70 sites coast to coast across 30 states in the US and enrolled at over 60 of these sites. And our sample size is 24, just over 2,400. That in a nutshell is what CHAP is, and thank you.
Thank you, Dr. Tita, and that was very helpful. Next, we would like to hear from Suzanne regarding the regards and the rules study. And I don't know if David Rhodes is on here too, if he wants to assist as well. I'll leave it up to you, Suzanne. Hi.
Yeah, no problem. It's just me today.
Okay.
So the regard study is a study that started back in 2003, and we recruited 30,000 people back then that we talked to every 6 months. We've been talking to them every 6 months since about 2003, and lost people. You know, obviously people die and people drop out, so we have lost some folks, but we were still following about 12,000 people when COVID hit. Again, given the way that we were doing the calls, our call center was down for a couple of weeks. But then once the call center got back up again, we were able to continue that cohort in much the same manner that it had been occurring prior to that. The one difference was we started doing in-home brain health visits to try to assess dementia. We were doing that in 1,000 participants, trying to get to 1,000 by the end of 2020, but those had to halt. And we still have had to halt those because we haven't been able to get to a point where cases are low enough in Atlanta, Birmingham, and Los Angeles that we have been able to go back into the home. So that was one major area of the research that had to slow down. The study also took on new data that I'll talk about at some point later, so that we could ask people about COVID, if they'd had COVID, if they'd had a positive test, if they'd gone to the hospital, so we could get a better feel from our cohort. And we're participating with the C4R program, which is going to send out blood spots to all participants, 8,000 participants in regards, so we can see if they have COVID antibodies to try to get a feel for antibody prevalence in this particular cohort. The rural study hadn't started recruiting yet. And in the rural study, we were taking a mobile clinic, we are taking a mobile clinic to 10 counties in the rural South. The first was going to be Dallas County, which is where Selma is located. And we've been doing a lot of boots on the ground work to talk to people. Longitudinal studies don't make sense to the public when you say to somebody, hey, I want you to come to my clinic and then I want to follow you for the next 40 years of your life. That is a very scary thought to people. So we wanted to be in the community, talking to people, letting them know who we are, giving symposiums, giving lunch and learns, so that it wasn't so foreign when we came in with this big truck. All of those community activities had to stop because people weren't getting together with COVID. So we lost some ground in terms of what we would do with community engagement, but we tried to do as much virtually as we could. We also had to slow down the recruitment so that we haven't been able to recruit people into the cohort yet. We do start visits though in June will be our first visits, and we're doing spirometry, which is an aerosol generating procedure. So we've got to take special precautions, and everyone will have to do a COVID test in order to participate in the visit. So that's kind of a general overview of the two studies, and I'll turn it back to you, Miriam.
Thank you. That was already some good information with regards to changes in operations with regards to COVID. We'll come back to that later in more detail. Next up, I would like to hear from Mike Sack.
Yep. Thanks, Miriam. So I run a cohort called CNIX, which is a CFAR network of integrated clinical systems. It was founded around 2000, and it's made up of now 8 CFAR centers and their electronic health record, where data is pulled from the EMR, it is culled, it is validated, and then de-identified and sent to a central repository in Washington, at Washington, University of Washington in Seattle. And the unique aspects of this platform is that it's really meant to be a resource for the world. So any investigator worldwide can submit a concept proposal and gain access to those data. And also we have specimens that are collected serially from a good number of the folks who are in the network. And those are stored locally, so it becomes a virtual network for the entire 37,000 plus patients who have been followed with HIV from the inception of CNIX. And then something also that we started back in 2006 is collecting patient-reported outcomes on clinic visits, which include domains of not just symptoms, but also substance use, alcohol use, depression, inter-partner domestic violence, smoking, in a number of other aspects, and we're able to use those data in real time to enroll patients into, as they're coming to the routine visit, can enroll them into clinical trials that are part of the routine visit. There's not like you identify somebody and send them to another group that runs a clinical study. It just is embedded within their normal return to clinic. And it can be, in some cases, a randomization to medical interventions. But what's, I think, really unique is that for substance use and that type of thing, it's certain behavioral interventions that can be embedded, and those interventions are done as part of the clinic setting, which makes it applicable, if it's shown to be effective, to be implemented in clinics literally worldwide. So CNIX obviously took a hit because this was point of care EMR data, and we had to shut down our in-person visits dramatically at all the sites. We went to telemedicine visits, but quickly pivoted and were able to collect data in a systematic way from the telemedicine. We also were able to create from scratch a, well, they've been working on it for a while, but to be able to take technology and do PROs from home. And that's really, those two things have really kicked us up in a way that we benefited in a back end away from COVID, because it sped up all the development of telemedicine capability. And it also gave us this new technology to do the PROs from home. So a lot of patients are electing to do that as they arrive or before they arrive in clinic for their visits. And we can also identify which patients get specimens. Another thing we were able to do very quickly was pivot to COVID-related disease among our patient population, and received a supplement last October, and within 2 months had a study that was organized and completed, and the data were presented last month at CROI, which is our big meeting. So the nimbleness, the ability to enroll patients and to get back to normal now. We're back in clinics throughout the country, but we still are now using telemedicine where we hadn't before, and these mobile PRO apps that are working quite well.
Thank you. Well, it seems like, you've had some setbacks, but actually, we're on the ground and on your feet very quickly, and would like to hear more later about some of the operations you've implemented, what you're planning to continue and whatnot. But before we do that, I would like to also give Dr. Bruce Korff a chance to briefly introduce the cohort and make comments, similar to the previous panelists.
Okay, great. So the All of Us research program is an NIH-funded effort, and it has the overall goal of enrolling about 1 million people across the United States, and with a deliberate effort to oversample individuals who are historically underrepresented in biomedical research. Participants will fill out some questionnaires about their health. They have some basic measurements, height, weight, blood pressure, things like that done. They give a sample of blood and urine, and then agreed to share their electronic health record on a longitudinal basis with the data center, which is at Vanderbilt. All of them ultimately will have their genome sequenced, and a variety of other things done over time with the blood and urine specimens. And then researchers anywhere can tune in on the data sets. There's a way of registering on a research workbench through the Vanderbilt facility to use the data to conduct research. And there's also a biobank of the blood and urine specimens at Mayo Clinic, and researchers will be able to gain access to that resource as well. Now, the All of Us Southern Network, which has its hub at UAB, includes sites at multiple places in Alabama, as well as Mississippi and Louisiana. So our 5-year goal is 93,000 participants. And as of the end of February, beginning of March of last year, we were a year plus into it and we had something like 25,000. And I can go into details later about what exactly happened once COVID hit.
So it's from what I'm hearing, and I also wanted to give Dr. Tita a chance to maybe comment a little bit more about COVID impact, because I think the other panelists kind of jumped ahead and already addressed that to some extent. But I'd like to start with you and provide any additional comments in terms of how COVID may have impacted recruitment of your study operations. And also collection of data points, ancillary studies that may have been added, or actually data points, having to be dropped and maybe going through a different follow-up schedule as you have planned. Any kind of changes that you implemented to adjust during this challenging year, but maybe also a year of new opportunities.
Yeah, absolutely. Just make sure, yes, you can hear me. So really, trying to address the challenges that, COVID-19 placed with the team, some there at the School of Public Health, was really under difficult circumstances, actually fun to do. So CHAP was in year number 6 of 6 as COVID-19 hit. We are currently in a no-cost extension, year 7, and happily last month, March, we hit our accrual milestone, so we are done with the 2,400 plus. But as we were actually looking to get done with that by, we were even thinking September or October. But once COVID-19 hit in March, we had an average of 40 or so per month, and that rapidly fell to 19 in March itself, halfway through as things got shut down. And then in April, we hit a low of 7. And then, subsequently in May, we're back to about 20, 30 on average a month. And then in March, as we were closing out, we hit 40. Everybody was excited to close out. But what we did compared to another network that we, are part of, we decided to really rely on the sites, and immediately as, things were going to shut down, asked all these sites, 60 plus sites, to come up with a COVID-19 remediation plan or strategy, more remediation strategy. And so we really rely on them to look at how people were reacting, across the country, and to, set up strategies to overcome the challenges really as soon as sort of proactively. And then we also emphasized safety. I mean, we made sure we really harped on the fact that you had to do everything to keep your staff safe. The good thing about CHAP is that the study visits are actually clinic visits. We did not require any additional study dedicated visits. So the problem with that is, as sites got shut down, then we had to immediately look for alternative ways to interface with the participants. So what did we do? We relied on sites to determine what was considered essential research, and used that to determine whether they were going to shut down or not. Some clinic visits were minimized. We set up virtual visits. There were some sites that bought blood pressure devices for all their patients. So we relied on home blood pressures as well to get patients into CHAP, and we had to immediately do IRB modifications, and the IRB came through really, really quickly. We came up with a new plan to ship medication to participants, set up remote consenting with different types. Some use Adobe, some Zoom, RedCap, consent via email, phone. And we also collect specimens at certain milestones, and So relied on sites to figure out how to do that, best. Many sites, though, continue to allow patients to come into the hospitals on a more, expanded basis or interval between visits. Some even set up what they call drive-through specimen collection hubs as part of clinical care, and used that as well for CHAP specimen collections. We also consider and offer the option for patients to be transferred, or participants to be transferred from one site to the other, as there was this outflow, or airflux out of New York, New Jersey. I don't recall that anyone actually ended up doing that. And then finally, we set up information, new data collection for COVID-19 testing. So we collect whenever COVID-19 testing was done or anyone had COVID, we have that. We propose a number of ancillary studies as well related to COVID-19. And then with about over 35 subs that, go with CHAP, it's been a challenge. It was really a big challenge getting subcontracts out, as the year ended and we started the next year. Overall, I would say that, we have these monthly meetings with NHLBI staff, and I think they've been very happy with the way things, went with CHAP, and, and really feel like amongst many of the studies that they do found that CHAP came out really ahead of the curve on that. So that's what we did. Thank you.
That's very insightful. And just to kind of comment on, or have a follow-up question on one of the things you said, given you have so many sites, clinic sites across the country, and it seems like, plans that were implemented, and probably also the ability to see patients during that time, and maybe follow-up time is different, between these different sites. Do you already have plans when it comes to the analytical phase, to account for some of that?
Yeah, great question. Absolutely. We work with the data center to track everything, where visits being done remotely. Obviously, when the COVID-19 hit, that will be an analysis, additional exploratory analysis that will be done. But we really tracked all the changes that we did, and will, even adherence to visits, adherence to medication, and we will take that into consideration in the analysis.
That's great. It's good to hear. And would like to hear probably more, in the future about how you handled all of this. I would like to now also turn to the other panelists and see if there are any additional comments with regards to changes and operationally, recruitment milestones, visits, modifications, and even, as I said in my last comment, analytical plans that you're anticipating, accounting for some of these changes that were implemented, especially if you're working across multiple sites in the country. We all know that the epidemic hit in different ways and different times throughout the last year, and continues to do so. So I see, Bruce, you are unmuted. I don't know if you have.
Yeah, so I didn't cover that when I gave my introduction, so let me just comment on how that was handled in All of Us. So you need to understand, first of all, that the All of Us program is conducted in very close collaboration with the NIH. Really, they call the shots, frankly, in terms of almost everything you do. And the central IRB is at the NIH. So when COVID became clear as a pandemic, NIH basically shut down all face-to-face involvement in All of Us. There was no wiggle room there. It wasn't subject to any local decisions. They just said you cannot continue to do face-to-face enrollments. People could still sign up online, but the physical measurements and biospecimen collection was suspended as of, I guess, the beginning of or middle of March last year. And it remained that way for a long time. I guess for quite a while, they were monitoring the COVID status state by state, in fact, region by region. And you had to be in guess it was sort of a green zone in order for them to even think about whether you could reactivate. And if you were, which was a pretty high bar to meet, as you know, then you first had to submit a safety plan as to how you would reactivate, which was also very demanding and very specific in particular. And of course, with our multiple sites, the circumstances regarding COVID differed in different places, even within our network. And each of them, and there were about 10 of them, had to submit a specific safety plan for reactivation, with lots of questions coming back from the NIH and ultimately approval, although even to this day, not all sites are completely approved for reactivation. So during that time, our enrollments we were actually the highest enrolling all of us network in the country as of March 1st, 2020, and it went from that to 0 and stayed that way. I guess for us, we began to reactivate at UAB really just a few months ago. And the first sites in our network that reactivated were the New Orleans sites, because COVID had simmered down there a little sooner than it did in Alabama. Now, during this time, while we could do no enrollment, we had a small army of study navigators who were doing all of the face-to-face enrollment. And most of them ended up being deployed for other kinds of projects that could still be done. But also the focus shifted from enrollment to retention. Retention in all of us means mainly the completion of surveys, including one survey that NIH launched. They called it the COPE survey, which had to do with the impact of COVID on sort of individual well-being. And so our team ended up spending a good chunk of their time on the phone in like tens of thousands of calls to encourage people to complete these surveys and to thereby be retained in the study. And that was really the main focus of activity from March until, to some extent, even today, but especially until this past few months as reactivation has taken place. So we shifted from enrollment to retention. Now, in the long run, I don't think our enrollment goals are going to change, but NIH has actually been very accommodating in terms of meeting the milestones. They're much more concerned about the safety of both staff and participants than they are about achieving recruitment milestones. And I'll tell you that things have ramped up at a much slower pace than before, because in the past we had sites set up, for example, in Kirkland Clinic near the phlebotomy area. And a lot of the people who enrolled were passersby who saw it and got interested. We're not allowed to recruit in that manner right now. The only way you can enroll somebody is if they sign up online and an appointment is made, and then that allows us to regulate the numbers of people who come through. But it's also putting a pretty significant obstacle in the path of potential enrollees. So the numbers are much lower now than they were. And I think we're just all kind of waiting for things to continue to settle down and for the kind of more normal enrollment to occur. Now, the one other thing that happened during this time, and I can say our group was a major kind of push to do this, was computer-assisted telephone interviews, because a lot of the participants were not internet savvy or didn't even have internet access. And that was and still is the major way of participating in surveys. And for a long time, the NIH wasn't permitting this sort of computer-assisted telephone interview technique. It took a while to get it through the NIH IRB, but our group actually, I think the Southern Network in general, has been the biggest user now of CADI, and it's been a tremendous boost in terms of at least the ability to retain participants, and probably over time, if the NIH permits it, will also be a boost to the ability to enroll. So that's probably been the biggest innovation that was kind of forced by the changes due to COVID.
Well, that's incredible. I mean, we all know the challenges with recruitment during this past year. So focusing on retention is definitely something that we all have seen in our cohorts, in our among our participants as being important, staying in touch with them. Suzanne or Mike, anything to add or from your?
Yeah, Bruce, it's interesting. We didn't get any guidance from the NIH. So we were shooting from the hip, making up our own guidance.
We did gladly lend you some.
Yeah, I was reflecting as I was talking that how much I would never want a pandemic to ever hit us again. But the amount of, we end up probably with more plus than minus at the end of the day. We're about ready to enter into a vaccine effectiveness study. So of all the people that get vaccinated, we have a captive audience that we follow longitudinally, and that's another project. I guess what I came away with the most is how resourceful the team that of all these different sites, we work together as a unit, and how really Johnny on the spot they all were to take advantage of the negative opportunities created, if you will. In other words, COVID comes along and it does destroy things and disrupts things, but there are opportunities within that.
Yeah, and I think we heard that from many of the panelists with regards to challenges, but overcoming them, and also new opportunities that have arisen from this. Which actually brings us to our next question for all of you. Knowing what you actually know now, and I think, Mike, in his last comments already hinted a little bit on this too, is would you have done anything differently with respect to, some of the issues we've discussed already, regards to participant recruitment, retention, follow-up, visit, data collection? I mean, not that we have the chance, but let's say we were to encounter something like that again, is there anything we can think of, to be prepared? And I think, it doesn't have to be a pandemic. We've also seen this with disasters such as, thinking about Hurricane Katrina when it hit New Orleans, and it also disrupted a lot of clinical trials during that time, and studies where participants were not to be able to be reached, and that was also not the priority at the time. But again, thinking about that, what do you think, would be something, you could or would do differently with your knowledge now? Ellen, I see you unmuted, maybe.
Oh, yeah, I will. Sure, I will. So, I think some of the strategies that we put in place as we were reacting to COVID-19 are things that maybe going forward we can consider. I think the landscape anyway is going to change. There may be more telehealth visits, so we should have in place, a framework to address some of these changes. So whether it's remote consenting, availability upfront, allowing for telehealth visits, and more flexibility in how you get the medications, study medications to, providers, home visits. I think, we'll think about these things upfront going forward. Now, that said, I will be very interested in seeing how these analyses that take into consideration these changes shape up. But those are some of, I think, some of the things we can do.
Anyone else would like to add to this?
Yeah, I think it's worth saying this, that part of the reason I think all of us had success in navigating really goes back to our institutional response. I mean, somebody mentioned, I forgot who said this earlier, but how the IRB quickly turned around a request. But it was more than that. It was getting funding applications in quickly. It was getting mobilized with all kinds of things. There was another project I was involved in where contract was set up in, I think, less than 2 days. That's unheard of. And so I think it shows that when there's leadership that says we got to get this done, and everyone sort of lines up behind that, that a lot of almost magical things happen. I guess my hopeful request is that we continue with that attitude and approach now that the epidemic is hopefully getting behind us.
Well, I vote on that one too. I think we all have encountered this in the past, but I also have to say, I think there's been a lot of leadership from the top, but also across the university, from employees, from faculty, staff, all around, to really step up to the plate. So I think that's been good to see, and it's been a great feeling, being at UAB and seeing that.
The other thing I would say is staffing. I mean, honestly, I would say one of the things that we learned, it's big. When you say, regards follows 12,000 people, I don't think a lot of folks realize that means we have about 40 people that work for us, because it takes a lot to follow that many people. And so we had to learn how to pivot and have people at home. But a lot of what we do is stuffing envelopes, so they couldn't stay at home. So we had to find ways to get them back. And some people didn't want to come back, so they resigned. And then we had to hire. So if I don't know who's on from UAB administration, but if I learned anything, it's always have open positions, always, so that you're ready if the pandemic comes to hire.
Couldn't agree more with that. That was very helpful. Yeah.
I think Mike made a good point in terms of the importance of flexibility, because with all of the efforts, whether it was institutionally to move things through quickly, or even nationally, think about the flexibility that evolved overnight for telemedicine. And as best I can tell, nobody got hurt because they loosened the rules. And I mean, it's actually a bit frustrating to watch them tighten up again when I think it was proved that this is really an effective way of communicating. So, part of the lesson is that, a lot of the bureaucracy and obstacles that are put in our path they do not need to be there.
Yeah, and this is not on topic for cohorts, but another great example of that, Bruce, is in the clinic, I can now get home oxygen for a patient just by making a phone call to a social worker. If the patient has COVID, it used to be we had to do all kinds of regulatory things, and now it's literally one phone call, and within 2 hours, the oxygen's at their home. And it keeps them out of the hospital and keeps them out of the ER. So it's obvious that we can do things differently. It's a question of whether we'll have any lasting effect in making that more permanent, that type of approach.
Which actually brings us back to another question that, and I think, you all already heading in that direction, what is it actually you think we can and should keep, in terms of lessons learned, operational changes? You already mentioned telemedicine. You mentioned, Mike, now the impact on just the ease of, prescribing something, that before, like oxygen, in a manner, that's, much more administrative, less burdensome than it was before, or the IRB. Bruce mentioned the NIH. It seems like the NIH hasn't been as flexible, but maybe they come along too. Again, what are the things, that you would like to see moving forward, as lessons learned, and also for specifically to your cohort studies, thinking about operational changes you've made, or other changes to your protocol that you will keep because you actually learned, first of all, and maybe beneficial for you, the participants, for the operations, etc.
One thing I would highlight is, I guess you could call it staff engagement. We've done a lot of community engagement over the course of the study. It's really kind of baked into how all of us is done, but there's the biggest thing that needed to happen for us was to get all of the staff on board and comfortable with their roles, which were evolving, with the speed of light in a way, and then had to pivot and evolve back to where they were, and then deal with added safety precautions. And I think we probably did learn a lot about just how to make sure that staff were comfortable with these changes and with the kinds of requests that were being made of them. And actually, I didn't mean to sound critical of the NIH. I think they were really doing their best to work through a, obviously global kind of issue that they were very focused on safety. Now, you could argue sometimes there was some frustration on the part of local investigators, not so much us as just nationally, that we knew our environment better than they did, and sometimes, and in fact, they gradually figured that out, and I think became more flexible. But they were very concerned about putting people at risk, and didn't want anybody to feel that the study took precedence over the safety of participants and staff. But I would just, we were already focused on community engagement. Engagement of the staff really turned out to be of key importance as well.
And that is something you think you will continue to do so, and as you go through your study with all of us.
Yeah, I expect that we will. It's a
anybody else,
people.
So in addition to some of the changes that we implemented because of the with technology, something interesting happened, and sort of an extension of what we are already recognized for in the country, because we are seen as being able to get a good proportion of our target population to participate in studies, at least in our obstetric area. But what we did was we actually had a lot more buy-in from the clinicians, even from our residents, from faculty, knowing that our research, we had to minimize risk. As they were having some of these encounters, they actually helped to introduce and talk about the studies and set it up for the research team, so that a research team member could call and then talk to a participant and get them on. But some of that teeing up and getting that boost from clinicians, I think, is something that we would like to. We had some of that we would like to continue to do. For example, a study on labor and delivery that was categorized as essential because it addresses postpartum hemorrhage, which is a major cause of maternal mortality. Our residents were all part of the IRB and a very pragmatic study to do that introduction to the patient, so that a research team member obviously did not have to go in to talk to them, and then they would complete, the enrollment using a phone call to the participant. That helped a great deal.
That's actually interesting to hear. So actually, restricting, or not restricting, but maybe being limited with some of your research stuff, but then again, others stepping up to the plate and taking on these roles, and maybe that's an opportunity to kind of nurture that and have them engaged in the future as well. And that would be something great to see in many of these studies, I assume. Anybody else want to add something, that they plan on continuing to do and lessons learned from this?
Well, I alluded earlier to the things that we benefited from in a backhanded way, like the app for the PROs will continue to use. Telemedicine, we'll figure out a better way to use it. And interestingly, the limitation of telemedicine, which makes me personally not like it so well, is that you can't really get blood work readily, or our usual STI screening. The blood work still is a challenge, but we're experimenting with home STI screening, where people would obtain the swabs themselves or collect the urine and send in. So there's another sort of backhanded positive outcome that could come from this.
Yeah, and I think we've all been thinking about alternative ways of data collection, specimen collection, and some of them have worked, some of them have not. So
and we could use a drone. Just fly by people's house, they put it on and send it off.
Yeah, or multiple, but maybe that's too much airspace. But with that, also, and some of you already have talked about this too, especially Mike, you have, with regards to ancillary studies and papers or, that have been added to this, COVID related, you've mentioned this, Mike, and I know others, I think Suzanne, you regards, I think also submitted supplements and with regard focusing on COVID among your participants, leveraging the cohort structure, the data, the richness of the data you already have, adding additional instruments or questionnaires, sometimes even specimens maybe. Can you, any of you, talk about that a little bit more, also about what's available, how people would go about contacting you to maybe being interested, either a student, helping with the analysis, or, if other opportunities arise, get involved. As we all see, this is still continuing and grants still get submitted with regards to COVID. What's the best way to connect with you, your research staff, if there are opportunities available and people interested to do so. So lots of questions in one. I know that's not what you're supposed to do, but trying to be efficient, Mike.
Yeah, so I think for us and probably for most of the other folks on the panel, there's a website, and our website has ways of applying to gain access to to data, specimens, whatever it is. And there's a mentoring component as part of CNIC. So if it's a student or especially younger investigator, we pair them up with a seasoned senior person, and it can be someone from any of the 8 CNIC sites who have particular expertise in that area. And I think that's another one of the added value things of what we do normally. So we want as many people who are not part of our team, if you will, to get engaged, because the more we do with outside investigators, the more successful we are, in my opinion.
Yeah, and I would agree. And just to add to that, in terms of websites, what we can do if helpful for participants of the symposium and those interested, if the 4 of you, can send us the links to your websites, we can then in a follow-up email make that readily available, so they have that and can follow up with you and your research team if interested. So, Bruce, I think I see you on.
I was just gonna point out, so, as I alluded to, we're not really in control of all of us data. It's a national data set, but I'll put it in the chat, but researchallofus.org is the URL to get to the researcher workbench, and UAB is registered as a kind of a site from which you can enroll in the research workbench, and that gives you access to all of the data that have been collected to date. You have to put forward a kind of a proposal, and you can mine kind of aggregated data now, and then there are ways to get access to more specific data and work with it on the workbench. But that's live now, and something which UAB investigators are certainly able to access. I'll put this into the chat.
That's very helpful. And Bruce, have there been any changes to your protocol to kind of add COVID related questions or any supplements that all of us has been associated with?
I don't believe they've issued supplements, but they have done some COVID-related studies. I think I mentioned the COPE survey, which was a survey about personal well-being. So those data are there, and they actually did do a study because they had been sampling individuals dating back, a couple of years at this point, to take a look at antibody levels kind of back in time to get a snapshot of when it began to appear. I think that work is still in progress, but those are a couple of studies that were done on a national level.
Okay, it's interesting. It's good to know. Suzanne or Ellen? Ellen, I see you unmuted.
Yes, yes, and very similar to what Mike and Bruce have said. This is going to be a really unique data set for pregnant women with chronic hypertension. So we encourage all kinds of collaboration. And it's a multi-center study, so we're responsible to the sites as well. But we've been able to do set up a good number of ancillaries already here. We hope to follow up this cohort. Currently, the follow-up is through 6 weeks after delivery, thereabouts for mom and baby. We hope to do a follow-up that will put these participants within a 5 to 10 year window, mothers as well as the infants. And I think there are opportunities there. Working with some on this call, Dr. Irvin, Dr. Hidalgo, there's an epigenetics ancillary that's getting a second. It was successful the first time, but Dr. Irvin was so successful that she had to do something else. And then the format and then we do have serial biospecimens as well, different trimesters. So the format for doing that is you can contact us. We'll send that information, and there is an outline, a concept, a description that can be done to make that happen.
Okay, that sounds great, and I'm sure with your cohort being high risk, hypertension being one of the risk factors for COVID and complications associated with it, that is going to be an interest in that direction as well.
Yeah, yeah, that's right. The DSMB actually, even before we were going to do it, it really reached out to us and said, collect COVID-19 information. So we have that, and hopefully can even look at long-term outcomes for the cohort that was actively in when COVID-19 hit. But we do hope to also, in fact, are in the process of collecting COVID-19 information for the cohort that was already outside of the follow-up window as well.
So I'm going to ask a specific question. Can you talk about, and I'm not sure if you have knowledge about how the pandemic has affected your participants. And this is, obviously a broad question in terms of, obviously their health is one aspect. I'm not sure if you're seeing higher outcome rates and, whether this is easy to see in, Alan, your study or in regards, but are you seeing higher outcome rates? Are you seeing a lot more dropout or have there been differences that you've observed?
Yeah, thank you, Paul. That's a great question. And I will extend or expand my focus from CHAP to other studies that we are doing and talk about a COVID-19 registry that we set up as part of the NICHD MFMU network. Several studies, papers are going to come out of that. We had about 4,000 pregnant women with COVID-19 in that registry, and then a random sample of those without COVID-19 as a control group. So we have the opportunity as a site to submit ancillary questions. No specimens were collected as part of that, but the initial paper out of that confirms some of what we know, that COVID-19 and those with COVID-19 infection may have worse outcomes in pregnancy in terms of, ICU admissions, etc. The things like preterm birth, NICU admissions, etc., are more likely in those with the, more severe spectrum of COVID-19, so critical care and ICU, maternal ICU. Admissions. I wanted to just mention that because I think there is an opportunity there. But outside of a conducted study, my observation, and I'm sure others on my team and maybe others here will agree, is that I think the participation rate in studies, right, getting patients to consent, I think that has dropped, and some of that may just have to do with so many other demands on our patients, on our populations due to COVID-19. And we have another COVID-19 study where we are asking them to do serial collections of nasal specimens and, to respond to text messages. And there are other sites, Utah and New York involved. And it's interesting to see how different these response rates are by state or by location. And I think our population here has struggled with many of those endpoints.
Okay,
Yeah,
thank
I
you.
would agree. I think that that's, we haven't actually looked at it formally yet. And often mortality, if mortality is the outcome of interest, that takes a while for us to get really good data on mortality because we do exit interviews to talk to loved ones to see what happened to the person and then get the hospitalizations that occurred in the month leading up to their death. So it'll be a while before we have outcomes like mortality. Heart disease, we're even a little bit more. It takes us usually a couple of years to catch up on heart disease. Cognitive decline may be the most interesting endpoint. We actually regularly surveil for cognitive function using several parts of various batteries, wordless learning, animal naming. So it may be interesting to look at cognitive function in participants. We haven't done that yet, but that would be one that would be interesting. I will say early in the pandemic, especially when people first went into their homes, participation in the every 6-month phone call was at an all-time high. People were answering the phone, they were talking to our interviewers. That has trailed off a little bit, but in terms of regular follow-up, we were able to stay in contact and do a little bit better than pre-pandemic.
Yeah, I might add to this. I've personally, as a researcher for 30 years, struggled a lot with mortality and cause of death. It's really, really hard. It's hard enough nowadays to even capture who's died out of a cohort. The death index, we used to have ready access to this and could download it. And then I guess because of identity theft and other things, they put an enormous number of restrictions, and you got to register and go through training and sign away your life and your firstborn child to even gain access to those information, those data. But even when you know who passed away, saying that they died from something and not with something is, in my experience, almost impossible to say it with confidence. There's a few entities that you say, yeah, this was clearly it. But especially, at least in my world of HIV, most people had well-controlled virus, and HIV was not a cause of death in hardly anybody, or nor were there opportunistic infections, but rather it was the usual types of comorbidities that other people die from, and knowing exactly what contributed when and how was tough. I don't know how you guys are dealing with it, but I've almost given up on determining cause of death.
Great.
And that's
So we
why
have
a
sorry,
more
go ahead.
extensive. I was just going to say the death certificate itself, I agree with you, Mike. It's just not very helpful. That's why we try to interview next of kin within 6 months of the person passing, and then get the hospital records so we can look at them ourselves.
Okay, great discussion. So we have a question from the audience about, do you handle sample collection differently now versus before? And some of us process the COVID samples in BSL-3+ labs, but it seems to differ institute to institute, and there does not seem to be universally agreed upon protocol for sample handling and processing as a whole. Any thoughts or comments about that?
I don't think our sample processing really has changed, but we're also screening people, hoping that people who are actively ill are not coming in for appointments. So I don't think it's otherwise changed in any major way.
Yeah, and I think that just obviously the biggest risk types of specimens would be respiratory secretions or stool. Blood itself, I think standard precautions should suffice, using a hood and using careful care with, I mean, yeah, could there be COVID virus in the bloodstream? Sure. but it's not at high concentration, and we're usually not aerosolizing in the processing techniques. So we haven't really done anything different for the specimens we've collected.
Thank you. So I'd like to ask a question about people who are interested in developing a research study now. You know, cases are low now, you know, but trying to be forward thinking and saying, what is going to be the important thing to study in the fall or in the winter? Is it going to be variants? You know, should we be, you know, if someone wants to say, what should I set up now? You know, is it something mental health related? I'm not sure, but you know, if you can comment about what you think is going to be important that we're not thinking about right, or a lot of people aren't thinking about now, but will be important to investigate in 6 or 9 months.
Well, I can get started for that. It's almost a laundry list, but starting at the top for me would be the evaluation of what in the world is happening with long COVID. This post-illness challenge that for about 10 to 15% of people who have had COVID where symptoms remain, and understanding the biology of that, I think is essential. First off, we have to come up with a definition, and we're almost there on that. And then the epidemiology, the pathogenesis, and hopefully one day the treatment, I think is a huge area. Even if the pandemic just stopped in its tracks right now, that would be something we I think should be compelled to study. The second thing is the vaccine efficacy, durability of the vaccines, the issue of variants to some degree. I think we should right now be implementing, and I think we are at UAB, an immediate flex for any positive PCR test for the virus should immediately flex to a sequencing of the key regions of the spike protein to determine which variants are being transmitted. I think doing that on a surveillance basis is better than nothing, but I think it should be universal because of the threat that variants pose, and we might start seeing the different variants cause different illnesses, and understanding that would be helpful from a clinical perspective. And I think breakthrough infections when the vaccine has been fully implemented, understanding that. And then finally, I could go on, but this is the other one that I think is critical for us, is evaluating people who have underlying disease that requires immunosuppression, and in particular, anyone who's on an anti-CD20 drug that like Rituxan or variants thereof, I think are essential to understand how the vaccine works. Does it work? What proportion of the immunity is driven by antibody against the spike protein that is not made well in people on those medications? But then flip it around and ask the question, is the T cell immunity enough? And I think it is, actually. Otherwise, we'd be seeing a lot more breakthroughs now than we're seeing. So that, I mean, I could go on for the next hour, but those are the things that immediately popped into my mind.
Yes, I would add the notion of host genetic factors that help to determine why different people respond differently to exposure to the virus, and why some people get extremely ill and wind up being on a ventilator, and other people have very few symptoms, maybe none at all in some cases. And actually, you know, the community really responded very quickly. I don't mean specifically at UAB, but internationally, setting up the International COVID-19 Host Genetics Initiative, which we and Hudson Alpha are partners in the Alabama Genomic Health Initiative joined, which has done an international study of host genetic factors and has identified a number that predict severity of illness to a degree. And we also, we pivoted our enrollment in the Alabama Genomic Health Initiative towards contributing to that, and also an NIH study called COVNet. We contributed something like 1,000 specimens of DNA from individuals who had been diagnosed with COVID towards a much larger data set to do genome-wide association studies. And together with Hudson Alpha, also have a project looking at whole genome sequencing in individuals who ended up with severe course that would not have been predicted based on age or comorbidities. So I think there's going to be a long time to fully understand what the host factors are, but this is another kind of ongoing research opportunity.
I just wanted to, since you mentioned this, Bruce, with regards to genetics, host genetics, and differential responses to COVID, I'm sure there's also going to be research that's going to, focusing on the differential responses to vaccines, and giving us the chance to better understand why some people react differently. Some of the more severe reactions we've seen that unfortunately had stopped some of the vaccines, but also vaccine hesitancy, which still is going to be a huge issue, and is going to, hold us back from where we could be, if everybody gets vaccinated in the long run. And I wonder also if somebody wants to add or comment on, the mental health aspects of participants, but all of us, I guess, but participants in your case, the impact it has had, and them probably also falling through the cracks, because if we do not have regular contact, and the same was true for clinical contacts, I think we've also seen, and we've seen that in our cohort, those that already have suffered from mental health disorders, or substance abuse, suffered even more through this particular time because, services were not really readily available. And the impact may have been, more, exponentiated among them than others. What can we learn there, and how can we make sure, that that doesn't happen, in the future?
The mental health piece of it will be huge, and there are lots of great studies at NIH to allow cohorts to start collecting data to understand how it impacts participants' health, so that we can pool data across multiple cohorts. I think that's going to be one of the best tools we have. But even beyond mental health, the original question, what might we see? As my primary area of research is nutrition. And when we do nutrition research in children, there's this phenomenon called the healthy child effect. And that's the fact that healthy children play with other children, so they are more likely to get upper respiratory infections. We just spent a year with very few upper respiratory infections, and I don't know what that's going to mean next year. So I think that's another thing to watch. Grandparents weren't around their children as much, and our participants may start being introduced to common bugs that they took a year off from. So that's another thing that I'm interested in kind of going forward.
Great.
Yeah, in short, I agree with everyone, and would just briefly say all of the above please include pregnant and breastfeeding women who are left out from so many studies. The vaccines, right? We don't know what happens in pregnancy, so those studies need to be done. Some are working on such studies. And then something that's intrigued me quite a bit on a global scale is just why some countries were hit so badly while others were not, even though some of the protective measures were not being undertaken. Now, more recently, some of these places have had a worse impact. And so that goes back to what Dr. Korff was saying. What really determines severity and the variation across individuals and locations?
Since you mentioned vaccine hesitancy, an interesting lesson to us occurred recently where the question came up, actually, I think it was raised by the NIH, whether we would, and I think this was true for all sites, be interested in providing materials about all of us at vaccination sites, figuring, here's a group of people who are aggregated, and it's a great opportunity to reach out, not to enroll them, but to just alert them to the opportunity to enroll in all of us. And we put that to our community advisory board, and they gave us some feedback, which I guess wasn't intuitive to me, but I think was important, which is that for many of them, the decision to be vaccinated was a really complicated personal decision. because there is a lot of vaccine hesitancy among some of the groups represented on the community advisory panel. And they actually cautioned us to be careful not to complicate that decision and kind of mix all of us into it, which was a separate, difficult decision for some people. And to be really careful not to kind of conflate the two, that people were there sometimes after a lot of soul searching, and it was not a great time to be encouraging them to participate in yet another study.
Very, very interesting point. So have you seen increased buy-in? This is a question from the chat box. Have you seen increased patient buy-in? And this may be for Bruce, who's recruiting people now into a study, but obviously open to anyone. But are people more interested in research now due to the recent positive, some would say positive publicity, or people are seeing the importance of research?
I was just going to say it's too soon for us to really measure that, I would say, because we're just reactivating, and I don't think we really have good data on that point. Intuitively, you'd like to think so, but I'm not sure I can quote any data that would suggest that yet.
Okay.
I agree. I haven't seen it yet, but I think it's possible. Certainly, everybody, the general public has become very familiar with what early use authorization means. They understand the difference between phase 1, phase 2, phase 3 clinical trials for vaccines. They understand FDA pauses, and which got released today, by the way, just now, for the J&J vaccine. So that's good that they've been instructed on all this, and also GMP, good manufacturing practices for all types of things, including vaccine development, especially in areas outside of Baltimore. So they're learning a lot, and maybe that'll help us in the long run.
I can initially say that we've had trouble in the last probably 3 weeks as we have ramped up trying to get people into the rural study. And a lot of folks are saying COVID. They're giving COVID as a reason they don't want to come down and participate in a research study. We don't have a baseline to compare it to because we started recruitment in April of 2021. But we definitely have heard, as we've called people on the phone, that they're not interested, and it's because of COVID.
That's our assessment as well with several other ongoing studies, that COVID is still really impeding participation in studies. I remain hopeful with what is going on.
This actually brings us also to a question. I mean, you commented on the positive, or Mike, alluded to how many of us and lay people as well, have become so to say experts, in fields that they never, envisioned, to have knowledge about, maybe clinical trials, etc. But it also brings us, I think, to the issue of social media and research and how that may impact research operations, recruitment, I think, too, and also the perception with regards to research and engaging in it. So that's something, and I think, I also know from other, studies, that they have actually ramped up their social media presence during that time because it was another way of communicating with participants. So how do you see that, in terms of, using it as on one hand, as a way to to communicate with participants and distribute information that's valuable, but on the other hand, also be a platform where the opposite can occur and misinformation is spread.
All of us has been an electronic enrollment from the get-go, which I think, I'm not sure that it took COVID to tell us this, but it does actually run the risk of enhancing disparities. And it's certainly been something that's obvious to us, that some people are far more able to access things, whether it's through social media or online, than others. Ironically, just as COVID started, we had been funded to have a mobile unit that would go around the state, really aimed to help deal with that very issue. And of course, that unit, I've actually never seen it yet. It's parked somewhere. I'm not at an undisclosed location, I guess. And sooner or later, it will actually be able to go out into the larger community. I guess the other thing, and it occurred to me was the question about whether people are more accepting of research. And it would be nice to think that they would be after all this. But at least from my perspective, the other thing COVID has revealed is this is maybe, I suspect, the first time a medical issue and a research initiative has been so heavily politicized and has become a cultural flashpoint. So on the one hand, you'd think a lot of people would be really excited and grateful that research happened. And on the other hand, it has brought to the fore exactly the opposite reaction from a subset of people, which is a bit scary to see.
Yeah, I started publishing my results on QAnon, and that's been helpful.
You'll have to send us the submission link, Mike.
Absolutely. I would agree, really totally agree with that. And I think I gave a talk this past week, last week, on just what social media has done to a physician organization. And frankly, sometimes I felt as though I didn't know what I know, right? In terms of how you do research and everything. I mean, it's really been a lot of negative information out there. And there are strategies to get at this, and I think even the UN, I used the UN example where they put a lot of different strategies to overcome some of the social media negativity. But I think we need to be out there and not be passive, because ultimately, especially with some of the claims that people are making, it becomes a question of life, versus death. So we need to have a social media strategy or outreach as well to counter in the right way some of this. Otherwise it's going to just begin to blow us away.
Okay, great. Well, we're nearing the top of the hour, so I want to be respectful of everyone's time. So I want to see if there are any last comments from our panelists before we wrap up.
We've learned a lot. And we've had to adapt a lot. I just hope we never go through another thing like this again. This was pretty awful at the end of the day. I think everyone acknowledges that. But so maybe the lessons we learn we can bookmark, but I really hope we don't have to implement them anytime again.
Oh, I was just going to say, I think we've learned a lot about resilience. I'll just leave it at that.
Okay, well, let's, since we're on Zoom, if we can at least provide a virtual round of applause to our panelists for a very invigorating and important discussion about research. And, hopefully this will inspire additional research to help improve the lives of people who have had COVID, the long haulers, but also mental health and other consequences. And so I'd like to thank everyone, and I hope everyone has a nice evening and weekend.
Yes, and thank you so much for the panelists and everyone else, attending. Please let us know any comments you may have or suggestions, if this was a helpful interest. Or how we can follow up, maybe even also with other cohorts and continue in this symposium session.